There we go. My name is Laffy Cleo. I'm one of the orthopedic sports fellows. Thank you for the opportunity to present today. We have no relevant disclosures. This is an OME study, however. And so tibial slope has been, studied for decades. And we understand that anterior tibial translation is increased, correlated with increased tibial slope. There's also cadaveric studies showing increases on the ACL graft in biomechanical studies. In clinical literature, I'm going to go through a couple studies here real quick. In 2013, the study out of Australia reported on the outcomes of 15-year follow-up of ACL hamstrings. And in their 200 patients or so, they had a 20% re-rupture rate. They also reported on 50 anytime ACLs, which were re-ruptures either in the ipsilateral knee or a contralateral primary ACL. When looking at those patients with a tibial slope greater than 12 degrees, they suggested that there's an increased incidence of further anytime ACL injury of 59% versus 23%. In contrast, in 2021, there was a study of over 3,000 primary ACLs done with a BTB autograft. And in this setting, among the ACLs that were primary ACLs, the incidence of graft failure versus non-failure really had a marginal difference in tibial slope of 5.4 degrees versus 4.8 degrees. There's no difference in tibial slope among their revision group. And when stratifying tibial slope above 10 degrees versus below 9 degrees, they found that in their primary ACL group, there was an increased incidence of a subsequent tear of 9.7% versus 4.8%. This was not significant in the revision group. And so they concluded that we should use caution when using radical interventions such as osteotomies based on these results. And obviously there's a discrepancy here between, their 9.7% versus the prior study of 59%. And so most recently, kind of the most complex patients, this study looked at those who had already failed a revision. And so they're undergoing a re-revision plus a slope-reducing osteotomy over a 10-year period from 3 institutions, 23 total patients, most of whom, or 40% of whom, received the allograft. And so they successfully reduced their tibial slope by about 10 degrees, but they still had a 13% failure rate, a 26% reoperation rate, and pretty low patient-reported outcome scores. And so they suggested that in these highly complex patients, it's still reasonable to use a posterior tibial slope greater than 12 degrees and a prior failed revision as an indication for slope-reducing osteotomy. Of course, all these studies and most of those out there use lateral radiographs as described by Jenin in 93 to measure tibial slope. In 99, MRI measurements were also described to measure tibial slopes and showed tibial slope averages 7 to 10 degrees, but noted the large range of tibial slope measurements among the normal population. And so the study I'd like to highlight is the one used in most of the MRI studies out there, and also the one we used, Hudak et al., published in Core in 2009. And so what they did is they found the central sagittal slice of the MRI, and they drew these 2 circles, which touch the anterior and posterior tibial cortices as well as the cranial aspect as well, and they bisected one another. So the line drawn between the center of these circles is what determines the longitudinal axis off of which the tibial slope is measured. And they had very good intra and intra-rater reliability in their study, but they noted that the tibial plateau, or the medial tibial plateau, on average had a 3.4 degree increased tibial slope on X-ray as compared to MRI. So you see in this graph from their paper, X-ray overestimated tibial slope compared to MRI. And in fact, X-ray has been shown to have varying measurements in many other studies as well. Dr. Spindler showed in 2007 intercondylar notch width varied with relation to knee flexion angles and tibial rotation. We have newer literature that has suggested that you cannot use MRI and X-ray slopes interchangeably between studies, even though, MRI by itself or X-ray by itself may have good reproducibility. As shown in their graph here, they're not interchangeable, as these slope measurements are a little bit all over the place. And so in a recent systematic review looking at ACL failures and tibial slope measurements, there were 20 studies which had 12 different measurement techniques and large heterogeneity in tibial slope values between these measurement techniques. And so this kind of set the groundwork for our study. We hypothesized that posterior tibial slope is not a predictor for ACL failure with hamstring autografts when taking into account predictive factors that have been previously described for ACL failure, as well as looking to evaluate the risk of ipsilateral surgery in 2-year follow-up. And so we conducted a prospective cohort study from the OMI database. We identified patients undergoing ACL reconstruction with hamstring autograft from 2015 to 2018. We excluded patients with less than 2-year follow-up, prior contralateral ACL, multi-legs revisions. We then measured the tibial slope. We had 3 authors measuring these, and we had 2-year follow-up of over 90%, but then subsequently an additional 44 patients did not have adequate MRIs to measure the slopes. And so before starting the study, I wanted to see, is this generalizable? Is this reproducible? Is this something that you can do in clinic and dictate treatment? And so I pulled up advanced tools in Epic, and I noticed really quickly that we don't have enough proximal tibia in most of our clinical MRIs to actually measure tibial slope as suggested in the literature. And even if you can make a guesstimate, as I did here, they don't have the center circles available to draw the longitudinal axis to measure the tibial slope. And even if you did have one, like in the lower left, that had enough proximal tibia, the axial rotation was off in the A to P direction. The coronal plane was off. Here you see the medial femoral condyle at the same level of the tibial plateau. And so it makes it a little challenging to measure an accurate tibial slope. And so we enlisted the help from our colleagues in the Program for Advanced Musculoskeletal Imaging Lab, and Dr. Zahler here assisted in creating the software for our study, in which we were able to make the longitudinal axis using the 2 circles as Hudak described. And we calibrated the axial rotation by establishing the transepcondylar axis. And as you can see, the anterior to posterior orientation of our sagittal slices were corrected in the medial and lateral plateaus. And we were able, as they described, to pick the midpoint of the plateaus in order to measure our tibial slopes as described in the original paper. And so statistical analysis was run to determine the effect of posterior tibial slope on the risk of subsequent surgery or graft failure using multivariable regression modeling. We controlled for patient and surgical characteristics that have been previously shown in the Moon data to perhaps predict re-injury risk. And 2-year outcomes were collected for the incidence of subsequent surgery or ACL graft rupture. And so we had 376 patients with 2-year follow-up. Average age was 23, average BMI was 25. The average tibial slope was 6 degrees, and our ICC for the medial slope was higher at 0.79 and still moderate for the lateral slope at 0.6. It's worthwhile to note that the interquartile range of our medial and lateral slopes was about 4 to 8 degrees, and 2 standard deviations of our population had tibial slopes less than 12 degrees. And so the majority of our patients received a 4 or 5 stranded hamstring autograft with an average diameter of 8.5 millimeters. We did have 27 revision ACLs, which is about a 7% re-rupture rate. And so this multivariable model was built, including those patient surgical characteristics we described before that are likely to predict re-injury risk. And when including medial and lateral tibial slope into this model, the ability of the model to predict re-rupture was not improved, as shown by the C statistic. And then the only factors that did predict the risk of ACL re-rupture was reduced age, as previously shown in the Moon data. And so once again, the risk of any ipsilateral surgery over 2 years was predicted only by increased activity levels at baseline and not by medial or lateral tibial slopes. And so here's a histogram detailing our cohort. As you can see, the blue is the re-ruptures in our cohort, and they span really a large range of tibial slopes. And if we draw a line at the 12-degree mark that's often cited for the indication for slow-producing osteotomy, we really didn't have a lot of patients, but of the 7 patients we did above that, only 1 sustained a re-rupture. And so the conclusions that we can draw from this study is that age and activity level remain the most significant predictors of ACL re-rupture with hamstring autograft. Medial and lateral tibial slopes in our cohort had a very strong correlation coefficient of 0.96. And in the future, we can use this study and this same cohort of patients to look at whether tibial slope is predictive of contralateral ACL injury or contralateral return to the operating room. We can expand to longer term follow-up. We could probably get 5-year follow-up by the end of this year. And then if we measure tibial slope on the radiographs of these patients, for those who have acceptable radiographs, we can look at this histogram, and if it's consistent with the literature that X-ray may overestimate by 3 to 4 degrees, and most people are using 12 degrees on X-ray, that would mean 8 to 9 degrees on MRI. and we would be looking at revaluing the data looking more like this. And so I'd like to thank all of the OME surgeons, and of course, big shout out to Connor and Michael for helping with measurements, and everyone else involved in this study. These are the references. Thank you very much.
So thanks, Laffy. Laffy did a fantastic job. Came into the fellowship year with an idea and kind of hit a roadblock with respect to evaluating these things. A lot of the things that are in the literature at our meetings look at full-length tibial X-rays when they're measuring for tibial slope. Certainly we don't necessarily have that data on most of our patients, and certainly Laffy, which she kind of downplayed here, kind of helped to innovate kind of a new process for sort of looking at this. And I think that's one of the other things that certainly came out of this study, was being able to, certainly stick to an idea that he had coming in, and certainly, make it work in a very scientific fashion. So, kudos to you, because there's, some centers around the country that are doing a lot of these osteotomies for patients who have revision surgery. We have some high-level surgeons here, and I think across the board, we're not really doing this much or at all in our own practices. And I think this sort of outlines why, we do things. And certainly the idea behind this for people who had larger dogs who have torn their ACLs. We have a black lab who's torn twice. And so you do a TPLO, a tibial plateau leveling osteotomy, to treat those dogs. You don't even actually do anything with the actual soft tissues. But that's sort of the whole idea behind this, leveling out the plateau. But it's a big procedure, and patients really don't do all that well in terms of patient-reported outcomes afterwards. And so I think this outlines some good and gives us some good parameters as to how we can move forward when addressing these patients with slope. Any questions? So this is
So is there a time typically graft failures at, or is it just cumulative over time? Is there a particular time that's springs?
So the literature shows that if we don't let patients return to sport for 2 years, that's when their risk of graft failure really reduces. But most patients are not going to wait 2 years. And so we usually use that 8 to 9 month mark to return to sport, because that's another, reduced risk of graft failure. So I'd say the majority of grafts fail in the first 2 years postoperatively.
And sometimes, for early failures, obviously, you're looking more at sort of a technique-based issue. So malposition, femoral tunnels, things like that, concomitant injury that was unrecognized, versus, longer-term rupture. So after 2 years, where that's sort of more anatomic-related stuff like that. Alex?
Is there a reason that you guys chose to typically look at hamstring autograft and think about looking at other grafts?
Yeah, it's a good question. And if you attend AOSSM this year, you'll see Connor's study presented there. They have shown, obviously, in the Moon data that hamstrings are more likely to fail. And then Connor did a study looking at hamstring diameter as well last year, which he's going to present. And so, the thought is failures are not that common. So you're going to want to get the best power. And so you're going to go for that fails the most. So I think that's one reason. Obviously, that 2013 study that I showed, Webb, where they talked about any time, ACL injury. The one problem I have with that is we already know that if you have an ACL reconstruction, you're already at an increased risk of having a contralateral at some point. And so then they double dipped that data, and they said, if you have increased tibial slope over 12 degrees, what's your chance of an anytime ACL? And they just double dipped and said, well, it's this. But obviously the confounder is that they're already at an increased risk bracket. And so they had 59% incidence. And that study is actually cited commonly in all of the literature that is building this narrative for requiring a tibial slope reducing osteotomy. That was it. I haven't seen that, but actually when we were doing this, we de-identified every MRI in every patient. And then we actually identified the patients that had contralateral MRIs, and in a de-identified fashion, we measured them. So I think we measured like 500 MRIs, but obviously there's only like 380 patients here. And so I just didn't have enough time before June 22nd, but we are gonna look at the data late to the contralateral side. It's a little tricky because some of those patients may have had that MRI, pre-op before an ACL versus, so, I mean, the theory of, whether they've grown since then, if they were, younger and stuff like that. So we have to look into it a little further.